All right, so switching gears here. We're talking about acute coronary syndrome. So first, definitions: myocardial injury is defined as any patient with a troponin greater than the 99th percentile without evidence of myocardial ischemia. So that's things like symptoms of ischemia, typical chest pain, new ischemic ECG changes, or new wall motion abnormalities on echo, and or acute coronary thrombus on angio, of course. So this may be acute or chronic, so that's myocardial injury. Myocardial infarction, or MI, is necrosis, again, similar to myocardial injury, with troponin greater than 99th percentile, plus delta, plus or minus, with signs of ischemia. So there's 5 types of MI, types 1 to 5. Most important to know are type 1 and type 2. Type 1 MI, again, so you need 2 out of the 3 criteria. You need troponin elevation, chest with delta, signs of ischemia on EKG or on echo, and typical chest pain. So type 1 MI is spontaneous plaque rupture, ulceration, fissure, erosion, or dissection that leads to intraluminal thrombus. Type 2 MI is a supply-and-demand mismatch. That's not essentially thrombosis, so that's not plaque rupture, but it's in the setting of most commonly sepsis, or infection, or any arrhythmias, renal failure, surgery, or heart failure. Other causes include vasospasm, microvascular ischemia, and non-plaque thromboembolism. So for these patients, it's important to know that to diagnose type 2 MI, you do need 2 out of the 3 criteria, just like type 1 MI, but there is like an inciting factor, such as sepsis, like I said before. So you need, troponin elevation with delta, ischemic changes on EKG, and typical chest pain, 2 out of these 3, with an inciting event to name it type 2 MI. So important to know about type 2 MI, it must have a clear precipitating factor. If not, if there is uncertainty, always good to treat like a type 1 MI until patients further evaluated. If a patient goes for angio afterwards, found to have a 50 to 70% obstructive CAD, so no stents, it's reasonable to initiate aspirin, beta blocker, and a high intensity statin. Next up, we'll be talking about evaluation of chest pain with high sensitivity troponin and differential STEMI and unstable angina.